Good morning. Thank you. Welcome to this new series in the videos about Cytosponge, a new diagnostic tool that will be introduced in the NHS for the early detection of Barrett's esophagus, where we'll be discussing the findings from the BEST3 trial as recently published in The Lancet. Here are Maria O'Donovan, consultant histopathologist at Adam Brooks Hospital in Cambridge, and Marcel Gehrung, former PhD student with Rebecca Fitzgerald, developer of the Cytosponge and currently leading with Cyted on the commercial aspects of this product. We'll be covering aspects of the histopathology as well as the sampling issues and the computer vision work that Marcel has been developing, and of course how this impacts our patients. I'm Marnix Jansen. I am a consultant histopathologist with UCLH in London, and I'm also a Cancer Research UK clinician scientist working on early detection of Barrett's. Maria, do you want to kick us off?
Great, thanks very much for that introduction, Marnix. I'm going to talk to you a little bit about the pathology aspects of Cytosponge and also talk to you about a patient's patient Cytosponge story. I've worked for many years with Professor Rebecca Fitzgerald, where I've been focusing on developing the laboratory processes for the reading of the Cytosponge sample. So Cytosponge you will be probably familiar with. It's a pill on a string, and the pill has got a capsule which encapsulates a sponge. The patient swallows the pill, the sponge is released in the stomach, and this is then withdrawn through the esophagus and out through the mouth, and it samples the entire esophageal lining as it's withdrawn. And the cells that are retrieved from that then are suitable for biomarker assays and also for the development of risk stratification methodologies. And that's what we've been focusing on over the past couple of years. The sample then, it's a wonderful sample because it samples the entire length of the esophagus, and so we receive over 1 million cells in these samples. And when you compare it to a biopsy specimen, for example, here on the right hand side of the screen, you can see there are 4 biopsy samples taken during endoscopy. Those are 2 to 3 millimeters in size, whereas the Cytosponge sample is 1.5 to 2 centimeters in maximum dimension. And there are far more cells, there's far more material to look at in that particular sample type. So this is the story, one patient's story. EC was a 69-year-old female. She was a retired research scientist, and she had a 20-year history of reflux symptoms. And these were well controlled with acid suppressants. She had previously been investigated. She had an endoscopy over 20 years ago, and this was entirely normal. She had an endoscopy on 2 occasions, and both of these were normal. Her past medical history was not significant. She had had an appendicectomy, and that was it. She lived with her husband. She was a non-smoker and consumed very little alcohol weekly. She had no known allergies, and her medications then were the acid suppressants or the antacids for her reflux. And because of her history of reflux and the fact that she was on these acid suppressants, she was invited to take part in the BEST3 trial. And she agreed to take part in it. She said she was happy to take part because she wanted to support science. And she also felt quite confident that her sample would be negative, given that she had had 2 previous negative endoscopies in the past. So she attended her GP practice. She swallowed the Cytosponge. The sponge was then placed in a fixative solution to preserve the cellular material for further studies. And here you can see the Cytosponge sample. The white flecks on the surface of the sponge are actually the cells that have been retrieved from her esophagus. And the sample was then sent to the laboratory for processing. The cells were removed from the sponge, and then they're concentrated. You can see them in this little yellow area at the lower end of this conical shaped tube. They're processed in formalin fixed and then paraffin embedded in this paraffin wax. And then very thin sections are cut and stained with a hematoxin and hyacin stain and ready for then examination under the microscope. esophagus, we would expect to see, in the biopsy, you see the normal squamous lining, which is just these layers of cells, which are entirely normal. And on the right here, you can see the lining from a patient with Barrett's esophagus, where you lose that squamous lining and it's replaced by these columnar or rectangular shaped cells that form this sort of ribbons of cells. And they contain these spaces which are filled with mucin. These are goblet cells. These are indicative of intestinal metaplasia. And these are characteristic finding in Barrett's esophagus. There's an endoscopic image here on the right-hand corner. The white area is and the red area. This is looking down into the esophagus, looking down through the lumen of the esophagus. The red area is the area of Barrett's esophagus. So this was her cytosponge sample. It was a very cellular sample, lots of cellular material present, and all these polygonal shaped structures. The pink structures here are the squamous cells. These are entirely normal. So there has been some normal esophageal sampling. But in addition, she's got this ribbon of cells, this strip of cells, which are columnar shaped. They're rectangular shaped individual cells, and they have these rounded goblet cell structures, which are areas of intestinal metaplasia. So this confirms that she actually has intestinal metaplasia and would be in keeping with Barrett's esophagus. And then we also perform an immunohistochemical stain, trephine factor 3 or TFF3, and this highlights these goblet cells, this brown color, so that we know that this is a focus of intestinal metaplasia in keeping with Barrett's. She also had evidence of ulceration. She had this acute inflammatory exudate with fibrin and inflammatory cells in keeping with an ulcer. She was then invited for an endoscopy based on the positive cytosponge findings. And on endoscopy, so this is again looking down through the lumen of the esophagus, and this is the lower end, which shows you the stomach. And so when we're looking at the inside lining of the esophagus, we can see that is this red color, slightly irregular, bumpy surface. It should be nice and smooth. It's slightly irregular and bumpy, which is abnormal, and also has this yellow area of ulceration on the 6 o'clock location. On autofluorescence imaging, the normal autofluorescence imaging color is this green color, and this is lost in her endoscopy. You can see that it's demonstrating a pink color in the lower end here. There's this pink color. And this is abnormal, and this is a characteristic finding in neoplasia or early cancer of the esophagus when you lose the normal color. So she had a biopsy taken, and this demonstrated Barrett's. There was high-grade dysplasia, which is a pre-malignant condition, and also an intramucosal adenocarcinoma. So there was an early cancer at this site. So her case then was discussed at a multidisciplinary team meeting, and it was decided that if her disease was localized and superficial within the esophagus, then she would be suitable for endoscopic treatment only and would not require an esophagectomy. So she had an endoscopic ultrasound, and she also had a CT scan. The ultrasound showed some thickening of the mucosa of the lower end of the esophagus. There were no abnormal lymph nodes demonstrated. CT scan showed evidence of regional or distant metastatic disease. So it was decided that she should have an endoscopic resection of the inside of the esophagus and the abnormal area. So this was during the endoscopic resection. This was the beforehand, where you can see these sort of nodules or bumps in the lining of the esophagus. And after the procedure, then this is what was left, where you're left with this sort of red area where the lining has moved. And we're now looking down onto a middle layer of the esophagus and muscle layer of the esophagus. So the sample was then sent to the laboratory, and this is what we saw under the microscope. So the normal esophagus is just in the corner here for comparison, the normal lining, but instead what this patient had, she had abnormal columnar epithelium with these abnormal glandular structures, and then they would become very irregular. They're crowded, they're at all different, they're spaced irregularly. And when you look at them closely, you can see there are abnormalities, and there's some variations in the shape and sizes of these glands, and they're extending deep. So this is superficial, and it's extending deeper within the tissue, but still just extending beyond the mucosa, when we examined the whole tissue resection, we were able to identify the depth of invasion, and it was superficial. It was just involving the superficial part of the submucosa. The deep margins were clear, and there was no evidence of vascular involvement, vascular space involvement, which would indicate a worse prognosis if it was present. So she had an endoscopy 5 months later, and there was some good healing. The white areas here are the squamous reepithelialization or squamous healing. There was still some red areas of Barrett's, and there was a slightly irregular area with a little bit of abnormality on the right-hand side of this area. And on narrowband imaging, this showed, again, a slight nodularity and also some variability in the vascular pattern at this site. And this was biopsied. It again showed persistent high-grade dysplasia and also a focus that was suspicious for intramucosal adenocarcinoma. So it was then decided that she should have a further endoscopic resection of this area. She had that removed, and again, it confirmed a superficial early cancer, a moderately differentiated intramucosal adenocarcinoma. This time it was more superficial than the last one. Margins were again clear, and there was no evidence of vascular space invasion. So she's been followed up 2 years since that second resection, and she's been completely disease-free with no evidence of residual Barrett's, no evidence of pre-malignancy or any cancer. So this case, in this case, the cytosponge is well tolerated. It is certainly a cost-effective screening device for pre-malignant and early cancerous conditions. This lady had success with screening with cytosponge. It led to diagnosis and also to minimally invasive treatment of her early esophageal adenocarcinoma, her early esophageal cancer, and ultimately to a cure. Thank you.
Thank you, Maria. That's a lovely example of early cancer detection whereby this screening tool effectively has also been used, which is really the goal for the whole method, of course, towards early cancer detection. Marcel, Maria and I have seen many, many biopsies of these patients. This is, of course, a completely new approach to screening the pre-malignant esophagus. I was hoping you could give us an introduction to your work on the computer vision aspects of this.
Great, thank you very much, Marnix, for the introduction, and Maria for the first part of the talk. And I will pick up some of the topics which Maria has touched on as well. In the next few minutes, I would want to give you a brief overview on the use of artificial intelligence and how we can support this pathology process, which Maria has demonstrated for cytosponge TFF3 for the early detection of Barrett's esophagus and eventually esophageal adenocarcinoma. To quickly recap actually on something which Maria has presented as well. One of the main challenges we have here from and also one of the opportunities we have here is that this is a fairly new sample type. And over the last many years, the team has built a very, very thorough understanding of how pathologists are approaching this particular sample type as well. And what our or my project of work was basically on is trying to understand this process in depth and building a computational framework which mimics these heuristics, how a pathologist approaches this type of sample. And to give a brief recap on what the data is we have here to work with is, this is what Maria has shown as well, but this is basically what happens to when cytosponge is withdrawn from a patient sent to the laboratory. We process the cytosponge and we get 2 slides with 2 different stains for one patient sample. One of them is stained with hematoxylin and eosin, and the other one is stained with trephine factor 3. Why those 2 different stains are important and are particularly important for how we deal with this data from a computation perspective, we will have a look at in a minute. But before we do that, I actually want to give you a brief insight into why we think that we need to develop assistive tools for pathologists to read cytosponge TFF3 samples. And to do that, actually, a couple of numbers here as a demonstration. Over the next couple of years, until 2025, we hope to roll out this technology into the wider NHS. And some early estimates here concluded that we would aim for around 300,000 estimated procedures per year. And if we do some simple maths here and assume that it takes us around 8 to 10 minutes of pathology review per one of these samples, we get to a very, very large number of 50,000 hours of pathology reporting required per year, which if we put this in line with the number of, for example, histopathologists available in the UK for that type of work, we're really hitting the boundary there. So this is something which needs to be urgently addressed, and hence that's something we started to work on a couple of years ago. The specific toolkit or set of tools which we use to do that is called computational pathology, which basically means using computer vision tools on histo or cytopathology images and trying to extract meaningful information from these images and then prepare or curate the information which you get out of this computer vision process and present it to the pathologist or interact with the pathologist in a way that it helps them to, first of all, increase the screening speed of those pathology samples, but also doing that without interfering with the diagnostic accuracy. And how you can do this is in many different ways, but to group it into the two most important abstract concepts, one of them would be full automation. And if we take this in the context of Cytosponge, what I mean here is if you look at the left here, we, for example, have a deep learning classifier which has been trained on individual regions or images of cells, which is able to look at the H&E stain and the TFF3 stain, and is able to give us a probability for what type of cell is present in a certain area of the image. And why making a differentiation between the H&E stain and the TFF3 stain here? That's because after working very closely with Maria O'Donovan and her colleagues and the pathologists who are very familiar with reporting the sample type, from a computation perspective, we basically divide the analysis of Cytosponge into quality control, which is mostly referring to looking at the hematoxin and eosin section, where we are trying to find gastric columnar epithelium to check whether the sponge has traveled all the way into the stomach. And the TFF3 biomarker we're using for the diagnosis to check for the presence of intestinal metaplasia. And to go back to these automation approaches, which I show here, what you can do is you extract, for example, this information from the images, you get some kind of estimate for is this certain cell type present we need for quality control and diagnosis. Then you do a fully automated classification and you generate a report. The big problem about this is that there's actually no pathologist involved in that. But one of the things which you will see now with a semi-automated approach, which we actually want to leverage by keeping the human in the loop here, is that machines or a lot of computer vision approaches are quite good at very easy images or very easy examples and make a call on them. But actually, the harder these images get, the more we would benefit from keeping the human in the loop and making a judgment on these cases. And what we can do here, for example, is we can actually extract additional statistics from these deep learning processes around how confident the algorithms are in making a certain decision. And then we can take the patient samples where the algorithms have a lower confidence in making an automated call, giving that to a pathologist, to an experienced pathologist for reviewing them, while all of the unequivocal samples would then be reviewed in an automated way, and thereby reducing the workload and giving only the cases where we really need the human observer for the pathologist, and thereby reducing the workload. As I said, we've put this in the context, we developed this framework and put it in the context of Cytosponge as well, and developed it, as I said, with these two different processes in mind around quality control of finding gastric columnar epithelium on H&E sections and finding positive goblet cells, those brown round ovoid cells, which Maria has shown for the diagnosis of intestinal metaplasia, and then stratifying those patient samples into those individual confidence classes, and then pushing the ones where we have lowest confidence to a pathologist for manual review. And how this looks like if we look at some data here, you can see this actually for the quality control task. At the top, you can see whether a pathologist has considered the Cytosponge sample as passing quality control or failing quality control. At the bottom, you see the number of areas in the image which might be indicative for this patient passing quality control extracted by an algorithm. And what you can see here, the further this number of detected relevant regions declines towards the right of the image, the lower the confidence of the algorithm gets, but also at some point where you see the low confidence bracket, it doesn't agree with the pathologist in all cases anymore. So all of these patients would benefit from having had it reviewed by a pathologist instead of going through automated review. But you see that the algorithm actually performs very, very well for these high confidence and no confidence regions on the left and the right side of the image. We can now do the same for diagnosis, except that here we can compare ourselves against two different layers of ground truth. The first one is, what did the pathologist say on the basis of looking at the cytosponge TFF3 sample? And also then, because this is some data where we had endoscopy data for the patients as well, what was the endoscopy finding for this individual patient? And again, here you can see that for the high confidence regions on the left and right, we actually get very good agreement between the automated assessment, which you can see at the very bottom, and what the pathologist says. And for the low confidence region in the middle, we can clearly see that the benefit from having an experienced pathologist looking at these images. And to take one extra step now, how this is basically implemented and how we validated this as well is by running this on two very large validation data sets. And we basically ran all of the samples through an automated pathway, except that we only took the automated analysis or automated result of patient samples and used them as the final result if they fell into high confidence categories, and we took and substituted the pathologist result into all of the ones which fell into the low confidence categories. And to summarize that, we call this a triage-driven approach. And one of the main goals here for us was to reduce the workload, and we could actually show in two validations that we were able to reduce that workload by 57 to 66%. We've validated this approach in over 4,600 slides from 2,300 patients, and something which was very important to ourselves as well, and something I referred to earlier about how we can use computational pathology for these types of samples. We also were able to ensure that we had stable diagnostic test performance, which means we had no decline in sensitivity or specificity, and only very minor decline or decrease or increase. And the same applied for using this approach on the BEST3 study, where we obviously look at positive predictive and negative predictive value. And exactly that stable diagnostic test performance was ensured because we were forwarding equivocal cases for manual review by pathologists. Thank you very much.
Okay, thank you, Marcel. I think that's a lovely overview of how you've pushed forward on the computational pathology there, analyzing these samples and also highlighting how this is a completely new approach, whereby you've used both the comparison with the pathologist's diagnosis on the sample as well as the eventual endoscopy diagnosis to really get a better understanding of the performance of the cytosponge readout. Maria, if I could just return to you, because I think that's an important point. As I said before, you and I have seen many biopsy trays whereby the standard method still of screening patients that are undergoing endoscopy for Barrett's esophagus, biopsies are taken every 2 centimeters along the length of the Barrett segment. We get 4 biopsies at each height. And this is, of course, a completely different approach. I was hoping you could say something with regards the difference in sampling and also possibly the heterogeneity that you might see comparing biopsies to this cytology approach.
Yes, Marnix. That's one of the big advantages of this particular technique. It's that you don't need to look at multiple biopsies. All your esophagus is sampled in the one specimen. And so the advantage there is that if there's an area that hasn't been identified by the endoscopist as abnormal, then the cytosponge will pick that area up. So it increases the chances of detecting any abnormalities within the esophagus, because you're not entirely reliant on the endoscopist identifying an abnormal area. Also, you have one sample to look at, so that it reduces the amount of time that it takes the pathologist to look at those samples. Because if somebody's got a very long segment of Barrett's, if we're talking about a 9 centimeter segment of Barrett's or 10, that's a lot of biopsy samples if you're going to have 4 biopsies every 2 centimeters. Whereas one cytosponge sample will sample that entire area. We have to, of course, be mindful that the cytosponge not alone does it sample the esophagus, it goes into the stomach. So you can get the lower end of the upper end of the stomach sampled, but also the mouth area, the oropharynx area is also sampled. So it's important that pathologists are then trained to interpret and to read these cytosponge samples, because you have to make sure that you're confident in the cell types that you're looking at, and that you can confidently say that what you're looking at is from the esophagus or stomach, or rather than from the oropharynx and the tonsillar area or the mouth. So that does come into play.
Yes, and I think for the histopathologists watching this, an important question will also be this: the technique is really rather simple. I've also seen it in patients whereby they swallow the pill, then wait a couple of minutes, and then the sponge is retracted. All of this can be done on an easy outpatient basis. Can these slides also be read in any histopathology lab in the UK?
No, they can't. And the reason I say that is, although the processing methodology is relatively straightforward, in order to make sure that we have consistency of the sample type, consistency of the staining, that we can audit the results, it's important then that it's done in a central laboratory. And also the training of the pathologist, as I mentioned already, is really key to this, because you don't want to have over or under interpretation of the samples. So it's really important that there's a unified pathologist group that's looking at these samples. Also helps with quality assurance. We have an external quality assurance scheme set up for this to make sure that everybody is reporting in the same way, and that the reports are standardized. And that's very helpful for the clinicians, that we issue standardized reports. So it's better to have centralized processing and reporting for this sample type.
Yeah, because obviously that's one of the main caveats currently to Barrett's diagnosis and also to dysplasia diagnosis is the subjectivity of the diagnosis itself. Marcel, I was hoping you could say a word to this with regards the future developments in this area for computational pathology in the pathology lab, or how this impacts the daily work of pathologists.
Yeah, I think that's actually quite an interesting question, especially in the context of cytosponge, where we have a very, very well constrained, and as Maria just mentioned as well, we have a very, very well constrained process, which enables us fairly easily to work with pathologists to target individual problems they're encountering, or bottlenecks for time, for example, which they encounter with this particular sample type. But more generally, I think there are three different areas in which computational pathology will impact those sorts of pathology workflows. The first ones are basically solving workflow problems, or approaching these things from a workflow perspective. So, for example, when Maria, or colleagues, or you as well, look at pathology images, making sure that your focus or your vision is directed to the regions that actually matter in the images. That's, for example, one of the ways how digital pathology tools or computational pathology is used these days. And then there's another completely new category, which is something we are exploring on Cytosponge as well, which is more around the prognostic and predictive characteristics. So can you see more than what a pathologist, for example, sees in these images as well? Is there a relationship of the underlying morphology to something we are not really aware of, that there is actually a relationship at hand there? And how can we build those tools to disentangle that and make that information available to the clinicians to further guide that patient care pathway? But yeah, so those are a couple of the different perspectives of where our technologies can make an impact in the coming years as well, and obviously particularly in the context of Cytosponge as well.
Yes. Maria, back to you. This is the method is designed to as a screening method for Barrett's esophagus. Is there also, have you been thinking about using this towards other pathologies as well? Are you picking up, are you thinking of patients with eosinophilic esophagitis, of course, a condition that's becoming more common as well?
Absolutely, yes, we are indeed. And we've been seeing examples of eosinophilic esophagitis in cytosponge samples during our trials. And as I mentioned with the patient who I discussed in my talk, she had an area of ulceration. So we're identifying inflammation. Sometimes you can have viral infections, herpes, etc. Occasionally can be seen in the esophagus, and we have identified that. Squamous abnormalities, so abnormalities of the normal squamous lining, where you can get squamous cancers and squamous atypia. We are certainly seeing those as well. We've identified Helicobacter pylori, which you can see in the stomach. We've seen that in some of the columnar epithelium that's come from the stomach. So there are a range of abnormalities that can be seen in the pathologists see in the esophagus that we do detect in cytosponge.
Yeah, that's really nice. And Marcel, are there any ways in which we could think of applying current biomarkers or biomarkers that are still in development to this technique?
Yeah, I think there are different aspects actually. One of them related to the point which Maria also just made. There's a lot of information in the H&E stain which is hidden in the morphology or in ever so subtle changes. And even if they're very underrepresented with respect to the thing you're actually looking for, that's where computational pathology tools can actually help, because they are objective when it comes to looking at the entire image, and they can highlight those regions, and they might actually show and highlight that region which a pathologist can miss. So you can sort of think as that computational pathology toolkit as almost like a bit of a biomarker which can help focusing the direction or focusing a pathologist on a specific region. But there's also other things which we have been working on in the last few years as well. And maybe that's something, Maria, you want to comment on as well. Working, for example, with P53 in the context of very specific patient groups to further guide stratification of these patients, especially if they come from a different target population than the one we targeted in BEST3. Maybe Maria, if you want to comment on that, how we can use P53 to support risk stratification of these patients.
Yes, absolutely. We're using P53 routinely now with patients who we know have Barrett's esophagus, and we're using it to help guide management in terms of their risk of. It is well known that if you have aberrant expression of P53, then you're at increased risk of progressing to neoplasia of the esophagus. And so we're now looking for that aberrant expression in cytosponge samples in patients where we know they have Barrett's esophagus, and they're being screened regularly for their Barrett's esophagus to see if they're showing any signs of progression to dysplasia or cancer. So this is a very useful biomarker. It's also useful in the context of squamous dysplasia, because the squamous dysplastic cases tend to show aberrant P53 expression as well. So it's useful in that context too. Although we see less squamous abnormalities here in the UK, but we have seen certainly increased numbers of squamous abnormalities in other countries, because we have used cytosponge at other high-risk squamous cancer areas, for example, in Iran, in China, and Africa.
Yeah, and I think finally, really, so this is really a beautiful conjunction of this new screening method to identify a kinder method to identify more Barrett's patients early. And Marcel, you beautifully illustrated your cutting edge computer vision work that's applied to this method. For the interested patients or pathologists out there who are currently looking at Barrett's biopsies, so where does this currently stand? What's next for the cytosponge, and what phase of development is this really?
So one of the things we have seen over the last year, and this was very much fueled by the coronavirus pandemic as well, is that the restriction in the availability or the limitation in the availability of healthcare services has put a lot of pressure on the endoscopy services as well. So the uptake and interest in cytosponge has grown rapidly over the last year as well, with large projects being rolled out in Scotland right now with NHS Scotland and also with NHS England. And we're focusing on right now to actually support support those limitations of endoscopy service availability by deploying the technology in secondary care where it's most useful at this stage. And it basically helps reducing the waiting lists in hospitals so patients can receive access to care sooner, because as you said yourself, Marnix, it's a kind of procedure. It's something which comes with less patient discomfort, and it's something which can be done in an office setting. It does not require as many people in the same room, and for example, exposure to aerosol than an endoscopy procedure needs.
Maria, would you like to add to that still?
Yes, we're currently, as Marcel has said, we are currently receiving samples from NHS patients. So this is now moved to the clinical setting. And that's very exciting for us. And certainly the numbers are increasing week on week.
Yes, that's also what's happening in my trust, Marcel, as you outlined this with the pressures on the endoscopy department with COVID, cleaning in between endoscopies. This has really filled a need. And we've now also started screening patients in this way. Well, thank you both. I think this was very interesting. If you're watching this, I would urge you to look at the other videos as part of this series as well. And thank you very much again.